session is being recorded, and so that's wonderful because I know personally there's a number of families who continuously have inquiries around dystonia, what it is, what it means, what's being done for it, and so I'll be excited to be able to direct them to this recording as another resource as they're trying to figure things out in the world of dystonia. So my name is Brenda Agnew, and I'm a member of our community council, and it's a pleasure for me to be with our panel today talking about dystonia. I have my son here, McLean, who is 17 years old, who has dyskinetic cerebral palsy, and so dystonia is a huge part of his life, therefore a huge part of our life. And my involvement today stemmed a little bit from being involved with Dr. Darcy Fehlings on the dystonia care pathway that I had the pleasure of being involved with. So really excited for the presentation today. So without further ado, I'm just going to do a brief overview. So this session will start with an overview of dystonia. What is it? Why is it important? How can we diagnose it? We will then transition to hearing from two parents who have children with CP and dystonia about how dystonia impacts their child on a day-to-day basis. An overview of the new AACPDM care pathway on management options for dystonia and CP will also be provided, followed by an open guided discussion. So our presenters today, starting down there, we have Dr. Darcy Fehlings. For those of you who do not know who Dr. Fehlings is a developmental pediatrician and professor in the Department of Pediatrics at the University of Toronto. She is a senior clinician scientist in the Blue Review Research Institute, Holland Blue Review Kids Rehabilitation Hospital. Her clinical and research work focuses on the innovation and evaluation of interventions for children with cerebral palsy, including hypertonia interventions, early detection, constraint therapy, dystonia, and pain management. She has led the AACPDM care pathways for dystonia in CP, and she has held positions as the inaugural head of the U of T Division of Developmental Pediatrics and the president of the American Academy of CP and Developmental Medicine, and the recent Lifetime Achievement Award winner that I'm just throwing in there. So congrats to you for that. We also have with us Dr. Bhooma, and I practiced earlier, I'm going to do this right, Aravamuthan.
Hey.
Yay, is an assistant professor and research director of the Cerebral Palsy Center at the Washington University School of Medicine in St. Louis. As a pediatric movement disorder specialist and neuroscientist, she conducts translational research on dystonia, these big words, pathophysiology in cerebral palsy. Her national leadership roles have included chairing and co-chairing these scientific programs for the two national organizations, the American Academy of Cerebral Palsy and Developmental Medicine and Child Neurology Society. She also leads the Cerebral Palsy Research Network's efforts for dystonia quality improvement. Her research awards include the 2022 American Academy of Neurology John Stock Movement Disorders Research Award and the 2022 Child Neurology Society Philip R. Dodge Young Investigator Award. She is married and a mom to 3 children, twin boys and a girl. And then to my left is Angi Harris, who is the current chair of the AACPDM Community Council. She's a parent of a young woman with cerebral palsy. Angela is also a clinical practice lead for nursing at a children's treatment center outside of Toronto. She supports the cerebral palsy and Botox clinics and tirelessly advocates for those with lived experience to ensure their voice and their needs are at the forefront. Well, I didn't. I already did me a little bit. I'm good. All right, I'm excited.
Well, we are totally excited to be here, and we're all really passionate about dystonia and really looking forward to sharing with you some of our perspectives. I just want to formally then introduce Brenda Agnew, and we are really pleased to have Brenda here. Brenda is one of our foremost parent advocates, and Brenda and I have known each other a long time, and it's a true privilege to be on this panel with you, Brenda, so thank you. We also were hoping to live link Hortensia Gemino here. She is from the United Kingdom. She's an occupational therapist, PhD, and is an early career researcher in the UK system. And she did all of her PhD work on a therapy rehab approach called co-op. We can't link her in live, but we have a really good video, so we'll be able to share that with you as well. So just in terms of the flow of the session, our biggest challenge today is going to be to stay on time. So I'm going to be the official time monitor. So we're going to start with Bhooma in terms of what is it? How do we diagnose it? And then importantly, we're going to transition to hearing a perspective from Angela. And then I'll come back and I'm going to try to do a 10-minute overview on the care pathway. And then we're going to move to Brenda to provide perspectives. And then I'm going to come back and the care pathway really talks about oral medications and botulinum toxin and intrathecal baclofen. But I will come back and talk a little bit about some rehab options. And here's where I'm going to share the video from Hortensia. Then if we've managed our time well, we're going to have some time for open questions. And then Bhooma's going to do a closing around where we're going in the future. So that's what we have in store for you over the next hour. And I'm going to turn it over to Bhooma.
Magic of technology.
Yeah.
Magic of technology.
Okay, so always excited to talk about. Oh. Oh. Look at this. Woohoo. Nobody breathe too hard. Okay. Always love talking about this topic. I'm excited to be here today for the community forum. I wanted to start with how we think about dystonia and CP as part of this diagnostic framework. So this is the SCPE, Surveillance of Cerebral Palsy in Europe, diagnostic framework for cerebral palsy. And you'll see that there are a couple of sort of branch points in thinking about different subtypes of cerebral palsy. Is there persisting increased muscle tone in one or both limbs, and is the tone varying? And then based on these questions and clinical exam, the guidance is to bucket people into having spastic cerebral palsy or dyskinetic or dystonic cerebral palsy. And the typical breakdown that's cited in the literature, and this varies a little bit, but it's roughly 85% spastic predominant cerebral palsy and roughly 12 to 15% dystonia predominant cerebral palsy. But in real life, we know that there's a lot of overlap between spasticity and dystonia. And this is just in our center, but there have been other studies published, including more recently a single center study out of Australia, where if we think about people with spasticity predominant cerebral palsy and dystonia predominant cerebral palsy, yes, those general percentages exist, but if you look at everybody in aggregate, what are the types of tone that we're seeing in a single person? These types of tone coexist in the same person. It is typical, and in many cases, at least half, if not the majority of people that we see with cerebral palsy have both spasticity and dystonia. Now, that makes it really hard to differentiate what in your own body is spasticity, or what in your child is spasticity and what is dystonia, and what is the functional impact of these different types of tones on your day-to-day life. So what are spasticity and dystonia? I am one of the renegade pediatric movement disorders physicians who thinks that dystonia is a type of hypertonia. Do not tell anybody else I said that, but that's how I think of it. I guess I told Darcy, so. There are generally three types of hypertonia. One of them is rigidity, which we rarely, if ever, see in true cerebral palsy. So I won't talk about it today, but if there are questions, I'm happy to answer that. Spasticity and dystonia we see commonly. So these are from formal definitions of spasticity and dystonia. So spasticity is increasing resistance to increasing speed of passive stretch. dystonia is voluntary movement-triggered overflow muscle activation that's arousal-dependent. What does any of that mean? When I think about spasticity and dystonia and explain it to families in the clinic, I think about spasticity as being there all the time to some degree. Now, it can change slightly. You can get a little bit less tight when you're sleeping. You can get a little bit more tight when you're sick. But generally, those muscle groups that are involved are always going to be tight to some degree. And it's also not typically triggered by something. It's always there, regardless of what you're doing. Dystonia is not that way. It could be there 1 minute and gone an hour later. It is by definition triggered. So it is triggered by attempts to move when people are handling you, like with transfers. It's also triggered by emotions, so that's what arousal dependent means. It tends to go away when you're asleep. It tends to be triggered by stress, by excitement, any sort of heightened emotion. And what our families tell us is that it also tends to be triggered by tasks where you really have to concentrate, where you really have to focus. So when I talk to families about dystonia, I say it's when, whenever you're trying to move or someone else is trying to move you, a part of your body that you do not want to move moves out of your control. And when I tell families that, they're like, oh yeah, okay, I know, I've seen that before. But it's hard to conceptualize it, I think, when you read the formal definition, right? So thinking about how we really see it in real life and learning from our families about how they experience it is really valuable for us. Dystonia has quite a big impact. It is one of the most common causes of pain in people with CP, causes a lot of functional limitations. People that are at GMFCS levels 4 or 5 tend to have more dystonia than people at GMFCS levels 1, 2, and 3, and vice versa. People with a lot of dystonia tend to be at GMFCS levels 4 and 5. The treatments for dystonia are very limited, and Darcy is going to get into that shortly in terms of guidance that she and her team have developed about how to address that. We know that the majority of people with CP have dystonia. The majority of people with CP have dystonia. That's a really important thing to know. It's not that 15%. Most people with CP have dystonia, so it's something that's important to recognize in all of us. But something that I have become really passionate about is it remains difficult to identify it. So when the Cerebral Palsy Research Network teamed up with community members, clinicians, and researchers in terms of identifying important research goals for dystonia, these were the top 5. You'll see that treatments is up there for sure, but diagnosis is up there too. This is something that we all recognize as being really important because it's a big problem. So in our center, a tertiary care center that prides itself on being one of the best children's hospitals in the US, only 30% of kids with a high probability of CP had their types of high tone identified by the time they were 5. So early diagnosis is a big problem. And even in older kids, only 13% of kids in our clinic who had their gait videos reviewed by 3 movement disorders experts, and then we said, okay, looking at their gait videos, they definitely have leg dystonia. When we went back to our own clinic notes the same day that those videos were taken in clinic, only 13% of those kids had leg dystonia written in the record. My clinic notes. There was no difference between me and any of the other physicians in our clinic. It's a 30-minute visit. Identifying dystonia is hard. And I think we all need to be really humble, even though we're all trying, but I think we all need to be really humble about what our ability is to identify dystonia in short periods of time in a busy clinic when there's a lot of other stuff happening. I want to talk briefly about our clinical QI effort to improve dystonia diagnosis in the clinic. One aspect of this was just improving how we were documenting dystonia. So we, across 3 centers, tried to very religiously document 5 items in our notes for everybody we saw with cerebral palsy. I've highlighted these middle 3 items as items derived directly from the hypertonia assessment tool, which was developed by Darcy and colleagues and is free to access through the Holland-Bloorview website. So we wanted to make sure that those exam items were being employed in the clinic. But in addition to that, knowing that even in the exam, it can be hard to pick up on some of those subtle triggered movements, we wanted to make sure that we asked the family about whether they saw variable tone. Because we know that you see your child for longer than 30 minutes, unlike me. And so it's helpful for me to hear from you in terms of what are you seeing at home? What are the triggers of tone that you see at home? Are there triggers? Does your tone go away when you sleep? Are they really floppy? Or are you really floppy when you're asleep? Do you feel like you tighten up when you get excited? These are all important things that we can ask in clinic that can give us something in addition to the exam for identifying dystonia. And when we did that across multiple centers, we were able to get everybody to do it, which in and of itself in medicine is kind of a big deal. And then after we did that, we were able to improve our rates of dystonia diagnosis from roughly about 50% across all centers to 69%. So it wasn't just that we were doing it, we were starting to increase the rates at which we were identifying it. And really, theoretically, the main thing that we were changing is asking families. So it really highlights the value of family perspective and lived experience perspective in diagnosing dystonia. I will go through this part a little bit quickly. We also talk to physicians about the words they use to identify dystonia, because a lot of, when I learned about dystonia, people senior to me were pretty much saying that, oh, if you see it enough, you'll be able to identify it, right? How frustrating is that? How frustrating is that? I mean, for a trainee, it's incredibly frustrating. How frustrating is that for a family? So gold standard consensus is a bunch of really smart people, or people who believe themselves to be really smart, looking at videos of people with cerebral palsy and identifying whether or not they have dystonia based on the videos, looking at triggers and seeing whether dystonia is elicited and agreeing amongst each other. How do you generalize that to an individual physician or an individual clinician in a single clinic visit? We tried to identify the way physicians described movements in different videos. And these are two young men, both with cerebral palsy, and one of whom has slightly more variable gait. When we asked physicians to identify the features of gait that they felt were dystonic in this child, they talked about the variability of gait, the legs variably coming in, the feet variably coming in, variable, 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 coming in, coming in, coming in. So over and over again, that's what physicians said during gait. When we looked at seated tasks, this young lady picks up her hand and does this. You can see overflow, and we're looking mainly at her legs right now. You can see that overflow, those legs coming in when it wasn't there before. This young lady, maybe a little bit harder to see. She's doing the same hand open close task. And then when she goes faster, do you see that? Imperceptible. Tiny little bit of overflow of those legs coming in. I would be hard pressed to catch that in clinic. This is a task that is really valuable to trigger dystonia, can be used as a part of the hat. But if you were to do this exam in clinic, there are kids running around, I'm trying to fill out a prescription, it's going to be hard to pick that up. So I think having a way for families to assist with this is really going to be helpful to all of us. In this video, I want to highlight that this young man's legs are quiet when he's doing the hand open close task, but what do we see in the other hand? The mirror movements. So I'll bring that up again in the next video. Something that our experts, our physician experts, really wanted to distinguish between was mirror movements in one hand. So when one hand was moving, mirror movements in the other hand in dystonia. And I'll bring that up again in the next video as well. Oh, am I at 10 minutes? Should I stop? Okay, all right, I'll finish up maybe like 2 minutes, okay. This is a summary of the leg adduction features that I mentioned before, the legs coming in and how variable they are, and how effect on gait function was something that really guided how experts graded severity. And then in these videos, which are videos of upper extremity dystonia, arm dystonia, you can see that there are different degrees of overflow to the other arm. So let me play this video very quickly.
There it is, yeah.
So here you can see that other arm, there's overflow when you start doing opening and closing of that arm. It's in this hand, but also at the shoulder. So the more proximally it moves up, the higher the severity grading that the physicians gave. And then in this video, with this hand, and there may be some overflow in the legs, but look at the hands. Very subtle. Do you see that spooning?
Yep.
That thumb curving up. Very mild dystonia in the other hand. Differentiating that from mirror movements is difficult. Something physicians talk about a lot when they are describing these videos. The key feature to differentiating that they felt is when you have a repetitive task, the other hand, if it's doing the same task with the same cadence and speed and type of motion, that's mirroring. But if you're doing this task and the other hand is doing something else, that's overflow dystonia. So differentiating between those things are important. Mirroring can be a typical developmental phenomenon, and dystonia, and in some cases, mirroring may be used as a functionally valuable phenomenon to help assist with certain tasks. Dystonia is different and may be functionally limiting depending on what the functional goal is for your family and for the person affected. So that is something that should be differentiated from mirroring and be treated. So if I were to summarize just that portion, thinking about the family's role in identifying variability in tone and making sure that you, if you're not asked, share it in clinic, tell your clinicians that this is something you're seeing, and then looking for variability in adduction, how much the legs are coming in during walking or even during a seated task where you're moving your arms and looking at the legs, and then looking at overflow in the contralateral arm when one arm is moving and differentiating that overflow from mirroring. So that last part is how physicians may identify dystonia in the clinic. In the last part, I'll talk about the next steps for thinking about how we can look at how caregivers are identifying dystonia. Okay, thank you.
Thank you, Bhooma. That was a whirlwind tour around diagnosis, and I'm sure some movement disorder neurologists could have learned some stuff from that as well. We're now going to go over to Angela and really important messaging about why dystonia is important. So over to you, Angela.
At our house, and I think within the community council, we say dystonia is like a swear word. Dystonia affects our children on a day-to-day basis, and we all curse at it. We've all had many, many conversations about how it really interferes with our children's day-to-day functioning. So my daughter, Elizabeth, was born at 25 weeks. Due to her early arrival, she was diagnosed with a hearing impairment in infancy. Her physical presentation puzzled many specialists, and quite a few other diagnoses were ruled out before her team came to an agreement that she had ataxia. Initially, balance and coordination were her concerns, and at 3, she struggled to maintain a seated position, then began to walk unassisted with her walker just over age 3. Around 10 years of age, she was diagnosed with spasticity, and Botox injections began. Looking back at my daughter's childhood, dystonia was present early on, but a formal discussion of how dystonia would impact her never really occurred. Signs of dystonia she presented included a heightened startle reflex. If she fell, it was almost like a startled goat. She would just fall over and absolutely be frozen. I'd have to pick her up in full form and seat her back up again. She'd frequently spill hot foods or drinks because she'd startle and then she would spill. And then if somebody bumped into her when she walked, she would fall over again because she would startle. And then when she was walking and she tried to increase her speed, her arm would get into a fixed position. But as a parent, I didn't realize that at the time. Often when we'd walk as well, I'd hold her hand and it felt like I was walking with a lightning bolt. You could just feel it like shooting through her body, but I didn't have the words to understand at the time that's exactly what it was. So then we tried the typical medications to treat her dystonia, but the side effects were not worth it. As well, because she had ataxia, most things made her ataxia worse. Deep brain stimulation was offered, but at the time it was a fairly new procedure and we weren't really willing to go that far. When my daughter was in her late teens, she was able to acknowledge more when her dystonia worsened, and through trial and error, we figured out what her triggers are and how to prevent and manage her triggers. For my daughter's stress, pain, poor hydration are her triggers. She may have painful cramping to her feet, in particular to her toes and her hands. And stress for her, we know is difficult to manage, but we know and stress at times like starting like an exam or a new job, we know her dystonia will be more temporary and we just need to be patient. And at the time, we just modify for accessibility. An example, she started her first job as a pharmacy assistant. She was so nervous at her first few shifts, she'd come home and her feet would be absolutely stuck in painful cramps. She talked with her manager and was given extra opportunities to rest, and she had shortened shifts, and now she's accustomed to her job. She no longer experiences dystonia at work. Pain is becoming more common as she ages, and it increases her in dystonia, and in turn increases her pain. So it's a vicious cycle. We try to stay ahead of her pain by using longer-acting medications, prescribed medicated creams, and now we're using a low-dose birth control to manage her pain for periods, which also would increase her dystonia. Poor hydration is also a trigger, and she's becoming more aware of the importance of staying hydrated. We've also noticed her dystonia improved after Botox injections, and in the time, have developed a Botox injection plan that addresses her dystonia and her spasticity. And looking at the new dystonia care pathway that Dr. Fehlings will discuss today, it makes sense how we saw after Botox injections. It was not anecdotal, but for us, it actually really works. So now she has injections to her rectus muscle because when she tries to pick up her leg, it tends to get stuck. And that, by doing that, that met her goal. Her goal is she's in a marching band, and she wanted to march, not in her wheelchair, but actually standing up. And so the Botox injections help with her with marching as well, because also playing an instrument increases her dystonia when she's marching. So it does reduce her dystonia in her leg and allows her to get her leg up and to march for short periods of time. She also has her gastroc and soleus muscles injected to keep her heels down, and that's for spasticity, and her tib post to stop her foot from turning in, which probably might be a combination of spasticity and dystonia. And her newest injections now are to her toes, because for her, toes for dystonia have always been really difficult and very painful. After her first injection, she remarked, "They don't crunch anymore, they don't hurt." And it was almost within a day with those injections. So the next time we went back, she asked the physician, "Can you do my other foot too?" So she definitely tolerates the injections much better than I would. So now we've increased her injections up to 4 months. So for us, it's been a bit of trial and error, but I think the most important thing is that finding that team. So talking with your physicians, and if your physician isn't aware, reaching out again. So for us, our developmental pediatricians and our physiatrists were the ones to help have those conversations and then find a treatment plan. We know that plan it's not perfect and it's not going to be consistent. We're going to change at times, but for us right now, that plan tends to work. And also to thank to Bhooma and to Darcy for having this interest in dystonia, because I think it's fairly new that there really has been this keen interest, and I think we still have lots to learn, and the care pathway is a tremendous start. Thank you.
Angela, thank you for such a powerful story, and thank you for sharing your story. It is really helpful to hear these stories about dystonia. Bhooma and I do specialize in dystonia, and we see these types of things regularly in our clinic. I'm going to try to shorten what I'm going to say just to keep us on time, because I want to make sure we have time for questions. But as clinicians, we are faced with a pretty significant impact from dystonia, and our evidence to inform what we should do is somewhat lacking. And so even though we don't have a lot of evidence, as clinicians, we're still needing to help to guide shared decision-making discussions. And in this type of scenario where you have a really important clinical problem and the evidence is a little bit equivocal, this is where an international clinical practice guideline can be helpful. And I was very privileged to lead this fabulous group in developing this international clinical practice guideline focused on dystonia and CP. We started before Bhooma Tour de Force came onto the scene, or Bhooma would also be on this. It takes a long time to bring a clinical practice guideline forward. I do want to highlight that you'll see a familiar face here. We have Brenda was a formal member of this guideline development and really joined every single conversation where decisions were made and brought that family voice to inform decisions. Don't worry about the details here. But I just wanted to tell you that we had to go through a very, very formal process called GRADE. And on the right-hand side, you'll see that we've pulled systematically all the evidence that exists for dystonia and cerebral palsy in the literature over all oral medications, botulinum toxin, intrathecal baclofen, deep brain stimulation, to systematically review the level of evidence. We then, in the middle, shift this evidence summary to a 12-step evidence to decision framework to come up with recommendations on how to guide care. And then in the third panel, it's just the high-level overview of the recommendations that were made. So, first thing is, you have to recognize that you have dystonia, and Bhooma's covered some of the complexities in doing that. Within that, we, in the guideline, wanted to differentiate focal dystonia treatment approaches from generalized. So you have to build that into the assessment. And then you'll see two really important circles here. One is that you need to evaluate dystonia over time because it fluctuates. So what you need today might be different than what you need in 6 months. So a continuity of care model where you're seeing the same person over time is super helpful. The other circle you'll see is everything can trigger dystonia, and please be on the ball as a clinician to try to figure that out. It's really important because if you've got a treatable underlying health comorbidity that can cause pain, that for sure is going to send dystonia through the roof. Common cause, constipation, really important, manage bowels. Any source of pain can trigger dystonia. Being anxious can trigger dystonia, and you can get into a vicious circle. So you do need to be aware of what is triggering. The other really important message that I've highlighted here in this other blue bullet is please move down the pathway only if dystonia is causing interference. There's very little evidence to support drugs to improve motor control. So it's really where the dystonia is causing toe spasms, the dystonia is making caregiving hard. When it's causing interference, that's when you want to move down this pathway. So what do we have in the pathway? The big box on the right, on the left. My brain is tired at this point in the meeting. Is our oral medications. And the first thing I want to say is that our evidence is limited. So the recommendations are based on low certainty evidence. But within the evidence, we've said that baclofen is our typical first-line medication that we might consider. Artane can also be a consideration, but we've ranked that a bit lower because the side effect profile is a little bit higher in Artane. Our benzodiazepine group, they can be quite effective at reducing dystonia, but they are associated with a higher side effect profile, and so we use them with caution. So baclofen first, Artane or trihexyphenidyl, benzodiazepines in that second line. And then despite that oral medication management, if you are still having difficulties and the dystonia is severe, then other oral medications that we might consider are clonidine or gabapentin. And then on the right-hand side, you'll see that we've got the focal dystonia posture. So you might have generalized dystonia, but have toe posturing. This is where you can consider botulinum toxin, for example. And then moving forward, if despite this oral medication and looking at chemodenervation for dystonia management, there are still symptoms that are really interfering, that's when we might look at our more invasive treatments such as intrathecal baclofen or deep brain stimulation. I really want to encourage you to go to the Care Pathway site. It is freely available. We're big on free. And we've made it to be accessible for clinicians, which means it really is accessible for families. And I want to encourage you to go in and read that Section 1, Evidence 1 summary, We've tried to write it briefly in about 10 minutes. You can read it through. And then I know there's more families than clinicians that want to read the full paper. And so we made that openly available to you as well. That's section 2. You can click on a link and it will take you right to that full paper. Don't do it at bedtime. It's a little bit dry reading. And then section 3 is our practical tools. You want to learn about the hypertonia assessment tool, you can link into the hypertonia assessment tool. And the other thing I want to highlight there is we've developed a clinician summary to highlight status dystonicus. That's where you have severe generalized dystonia that is causing some health issues. And we found, particularly in our earlier work, that emergency physicians weren't aware of status dystonicus, and it can be really a life-threatening condition. So Dr. Lynn has really moved this work forward, and this is just a practical tool where we can grade it from 1 to 5. And then the next part of the tool just gives you some treatment options. So it's something that's nice to orient to. Just a few closing comments. Oral medications, I try not to use them if I don't have to, but I'm seeing a lot of children with dystonia where I do have to consider them. There's a lot of variability amongst healthcare providers in terms of their approach for oral medications. We have minimal information on long-term cognitive impact, which is really our concern. You know, we're trying to balance the potential positives, but what are the side effects of taking long-term medications? And for myself, I reserve oral medications for dystonia that is causing interference. Really important, and we really heard this strongly from our family panel, that shared decision-making is really important. And the other message I want to say is trial the medication, because you're going to get individual responses. So by trialing the medication, if it's not working, make sure that that medication is weaned. So I'm going to turn it over to Brenda now to give you some really succinct, pithy comments on this care pathway.
And so I don't know. I mean, I'm not one to be known to be succinct, Darcy, but I will definitely
Brenda.
try.
You're great.
But I will say that, you know, in the discussions that we've had today, I've really framed sort of, you know, my ability to comment on this. And dystonia is something, as you know, Angela mentioned, that is very prevalent in, you know, the discussions that we have amongst parents and in the CP community. But it's a relatively newer conversation. Dystonia, as Bhooma had referenced, isn't something that we would talk about typically or you know, regularly when it came to cerebral palsy. We always, you know, it was hypotonia, hypertonia, spasticity. The dystonia didn't really come into things, and we're seeing it come in a little bit more and more now. And the importance of the pathway. So the process in itself, as Darcy outlined, was extremely important. We had a variety of different people from a variety of different geographical locations who all had experience in a number of different ways as it pertained to dystonia. And we had really, really robust, in-depth, engaging discussions about these interventions and what they meant, what, you know, what they look like. We had chances to talk about some of those anecdotal pieces, especially from a parental perspective. You know, like cannabis, I'm going to say it, right? It came up. It's something that we hear about in our parent communities, and we hear about, you know, the use of cannabis when it comes to diagnoses like this, you know, and I was very quick to say, why is that something that isn't here, and the evidence isn't there to support it? So we were able to have these really, really great discussions around the evidence that we did have, recognizing the shortfalls in what was available, but, you know, being able to hone in on what we did have access to. And so, you know, being able to develop the pathway with all of that information, being very clear, very laid out, and very evidence-based was important. And for a few different reasons. I think one is that parents want to know, when they hear this word, they want to research and understand more about it. And the access to dystonia resources was very lax. It's still a little bit lax, but it's much better now, and the care pathway is a huge piece to this. And so parents can go in and take a look and see, okay, I've heard this diagnosis, I'm not sure what it means, what's available to me, what are the things that I can consider, what are the things I can bring to my care team for shared decision making, and it's all laid out there. Because the other thing is depending on where you live and who you have access to, we don't always have access to a Holland Blue Review or to someone who has, experience in dystonia and what some of those frontline interventions might look like. And so having having access to a toolkit like this that we can take, that people who are in different areas can actually take to their treating physicians or take to their team to say, what about this? What about this? Is this something that we consider? Is this something that we could take a look at? And so, from my perspective as a parent, and the parents, I know I'm looking around here, we were excited for this to come out. We were, really, really looking forward to having this resource be available for all the reasons we talked about earlier. And so I do encourage people to go and take a look at it and to educate yourself as much as you can if this is a diagnosis that is floating around for your child or for someone who has lived experience and wants to know more about it. And then the nice thing is, too, I think it's a starting point. It's something that we can go back and reference and say, how is it going with this? Has there been more research? Are we able to build out on that? But there was just so much lack of information, as I said, out there. The dystonia care pathway really did bring it together. It really is succinct in a lot of ways. It brought together a number of different stakeholders, which is very, very key, including the parent perspective. And so I'm really, really proud of it, and I'm glad that people will have access to it. And I would encourage you to let people know that it does exist and for them to take a look at it, because there's a lot of really great information there.
Brenda, thank you so much. That was very succinct and very important.
Thanks, Mom.
Good job. All right. I'm going to see if the video plays from the slide, and if not, I'll escape and play it from elsewhere. But we've talked about what's in the care pathway, which is focused on oral medications and botulinum toxin and intrathecal baclofen and deep brain stimulation. But rehab strategies are really a cornerstone to helping to manage dystonia. And I just wanted to bring two rehab strategies that I think are important for dystonia. So one is looking at cognitive behavioral therapy strategies to learn mindfulness and relaxation, and it's very much endorsed by families, and the nice thing is it doesn't have side effects. So here's a really fabulous little video.
Imagine that you are a pufferfish being gently pushed and pulled by the dancing ocean. Let's do some breaths that can calm us down when waves of big emotion hit. Breathe in and feel your belly expand. Hold all the air in your cheeks as you puff them out. Hold it and slowly breathe out. And return back to your relaxed pufferfish form.
Now, isn't that cute? And again, freely available. There's a few different ones. The pufferfish is my favorite. If any of you have watched the Limitless Chris Hemsworth series, they talk about box breathing, but the pufferfish is better than Chris doing box breathing. So let's transition now to hear a little bit from Hortensia Gemino, who has developed or evaluated what's called co-op program. And she'll give you an orientation for it, and it's something that I'm quite enthusiastic about. So let's see if we can get the videos up and running.
Occupational performance is, and a little bit of the work we've done, I don't know where to put my camera, a little bit of the work we've done with children, young people with movement disorders. This is Grace. She wants to ride a bike, and she's been wanting to ride a bike for 10 years, and we've been focusing on I guess, what's wrong with her body or her hands, her legs, and trying to fix those impairments in a way. But we've never actually focused on what matters to her, which is putting her on a bike and start bike riding. And this is very much in line with some of the lack of evidence around what matters to patients, to children, to young people and families. And unfortunately, we don't have any definitive trials to understand how we should be offering non-pharmacological and non-surgical treatments. So this is Grace. And this is how much you can do before we started working on co-op, and co-op was part of my my studies when I did my PhD. So this is how much she can do. And my goal was to ride a bike in 10 meters straight. And obviously, you could say that is not a very functional goal. You can't go anywhere, for 10 meters. But that's the goal set herself. And the really important thing is what she was able to achieve without other people or without me as a therapist. And she explained to the others, she came to present with me at a conference, and she presented and she introduced the idea of co-op as you have some functional goals that you want to work on, you want to achieve. And what you learn during the intervention is to analyze where things are breaking down and to come up with strategies yourself, and that's what the therapist helps you do, come up with strategies to solve those problems in daily life. And what is really important is this generalization and transfer here, which means that the strategies that you learn by doing bike riding, you can apply to other things like doing your eyeliner, for example, things that you don't need to work with your therapist. She was able to use the strategies that she had learned before, and you saw how much she could do after the intervention. And this is what she started to do by herself 3 months later after I came back. She was able to obviously ride the bike for much longer. She was able to go out with her siblings, go out as just one more of the friends. And she was stronger. For the first time, she actually showed that she had made some changes to those impairments, like strength, fatigue, and she hadn't worked on any of the underlying impairments. She had worked on something that she was really motivated to do, which was to ride a bike. And the really important message around this is not so much that she learned to beautifully ride a bike, but she explained it at this conference. It was a national conference in the UK, around how much confidence this had given her. And it wasn't about riding the bike, it was much more than that. It was the constant belief that people had told her that she couldn't do things because she had cerebral palsy, because of her involuntary movements. And it's almost, she explained it like being really bad as a subject in school for years, and everybody's told you that you're never going to pass it, never mind do well on it, and then you have to take the biggest test and you get an A+. So the intervention focuses on, is based on a learning paradigm, it's a metacognitive intervention, and is using these problem-solving strategies that we support children, young people to generate. I think the research that we are doing is telling us that probably motor performance is mediated by cognition much more than we originally thought, and this is really important in terms of any new interventions that we might be developing. And I talk about non-pharmacological, non-surgical interventions. And one of the things we're doing right now that we've got some funding and we've started, we're just in the setup phase, is start looking at how can we measure things across trials for patients, for children, for families to be able to make decisions based on the same outcome. So we're doing.
And I'm just going to pause it there, just from a time perspective. But Hortensia was part of the Care Pathway group, but really trying to move forward this rehab strategy and doing it within an evaluative framework. And Hortensia would love to have been here with us today. And she's also very open to having questions. And so please feel free to reach out to Angela or myself, Brenda, and we can put you in contact with Hortensia. So at this point, we've got 5 minutes left, and I want to give Bhooma the last minute. So it means we have 4 minutes for questions, but please, if you have anything burning that you'd like to ask any of us, we would be very open to receiving questions. Yes. Yes, although I'd say the most frequent thing that happens is when an individual with dystonia, particularly dystonia and cerebral palsy, is trying to do something, that voluntary movement can actually trigger or worsen dystonia. But I'm also going to turn it over to Bhooma, who is a movement disorder neurologist and has probably seen many more people with Tourette's than myself.
Yes. So I think that's a really interesting question. So in adults with dystonia, there is something called a task-specific dystonia, where doing a specific task will bring out a dystonia. And in particular, in musicians, you can have a musician's dystonia, where someone who's a concert pianist, it is in fact while playing a piano that they will have dystonia, and otherwise they won't. We don't usually see that sort of manifestation of dystonia in cerebral palsy. Usually in the people with cerebral palsy we see, it is exactly as Darcy said, these voluntary movements are triggering dystonia. I do think, though, the similarity that I see between tics and dystonia is that I do think that there is a motor pathway in your brain that is entrained in a certain way. It's a path that is stuck doing a particular movement, and it's a different set of neurons that are doing the tic than doing the dystonia. But I think some of what Hortensia showed is that because it's a pathway that's entrained, you can also reteach that pathway to do something else. And so that concept of neural flexibility, I think, is still there, but not quite in the way that you described, I think.
Thanks for the question.
Yep.
Yes. I'll start, and anybody can join in. So dystonia is really frequent in all parts of the body. And when we looked for it, I was involved in the population-based study that came out with James Rice as the first author. We found it in 75%. We saw it in upper limbs, we saw it in lower limbs, we see it in the neck, we see it in the face. The trunk, sometimes we see twisting through the trunk, but we also see commonly low tone through the trunk. Within an individual, the postures that they get stuck in can also be variable. So that speaks to that continuity of care model where you're following an individual over time, because they may present with a significant posture in their upper extremity, and then you see them again and it's on the other side and it's a different posture. So see the person in the moment and look for where the interference is happening. Bhooma, did you want to add to that?
No,
Yeah.
I agree with that completely.
I just wanted to make a quick
Yes,
comment, Darcy,
please.
really, really quick, because I know we're cognizant of time. But, this conversation around the importance of CBT and some of these other mechanisms, I think is really key. I think there's a tendency, and I understand that as a parent of a child with cerebral palsy who has dystonia, to take a look at those pharmacological options. But, in the absence of those, or in the moment, or things that can contribute to the entire picture, I think those are really important. And, anecdotally, I talked about, McLean will kill me, but anecdotally, I talked about, last night we were in a strange place, doing a very routine process of shower and all that kind of thing, but, didn't have all of the same elements. And, dystonia was not our friend last night. And I said, one of us is not going to make it out of here. But what did we do? I did this, and I was doing it the whole time. The whole time we were sitting here, I was doing this, because in that moment, I didn't have access to more medications. I didn't have access to anything else, McLean. And so it was able for me to say, okay, what do we have control over here? Can we? And he kept saying, it's my dystonia, it's my dystonia. And I said, I know, but bud, let's breathe. Let's work through this. Let's try. And really, when you're in that moment and there isn't anything else available, that's a really important intervention.
I really think we need to up our game as clinicians in providing this guidance around deep relaxation, some cognitive behavioral therapy strategies. It's really what we're interested in. And then Hortensia is really pushing the envelope in terms of improving motor control for individuals with dystonia. I promised Bhooma the closing comments, so over to you, Bhooma.
Oh, well, okay, it's a lot of pressure. So I think in terms of summary of things that I want families to take back to your clinicians, to your families, to your people affected by CP, just know that your descriptions of movements really matter and can guide treatment. So make sure to tell the people that you feel are making the decisions about your treatment, the movements that you're seeing. And I think that can be really helpful in identifying whether or not someone has dystonia by saying whether or not you see variable tone. Know that there are other diagnostic methods on the forefront. I know Rishabh's sitting in the audience. He's developing an automated way to identify dystonia in the legs. And so there are lots of people working on this. And then the last thing I'll say is we obviously need more data on treatments for dystonia, and so that's work that's ongoing to actually try and compare of the treatments we're currently using head to head, which ones actually work, which ones are changing dystonia in our families. The last thing I would share is that educational materials for families is growing, is necessary and growing. There is something called the Dystonia Toolkit being released by the Cerebral Palsy Research Network. It's coming in the next month or so. I have little cards, promo cards that I can leave for everybody. So please make sure to take one. A lot of the information we've talked about today is summarized in those toolkits.
Perfect. Thank you.
And can I say a big thank you to Brenda and Angela for joining us on this panel. Really